So I would be glad and happy. I seen almost more than 100,000 registered patients and coach more than 1,000 doctors. My primary area of interest is hemato-oncology and bone marrow transplant, but I'm a quite good speaker, so you're gonna get the excellent overview of the MCQs and how to prepare. These are the main key things what we provide is a PROMETRIC 1000 MCQ book and ebook, online subscription and coaching. Coaching is the same way what we are doing it now. That is coaching. We have a WhatsApp subscription, Oman Viva coaching and subscriptions, data flow services. For all specialty, we have some short money back guarantee packages as well, especially those who are going for second or third trial. We have excellent application on mobile phone, Android and iPhone. So if you are interested, you can download it. It's free of charge and that will help you a lot. Another thing is we have excellent dedicated mock test series on our website. Unfortunately, not much doctors are utilizing this, but I'll assure you, if you do the mock test, they are really good and that will going to give you the good self-assessment, how you are doing, where are you standing, how much is your score, where are you doing the mistake. Lots of self-analysis can be done on the mock test, and this mock test is designed in a such a way, the way exactly you are giving the exam in your room. Right, so everyone should use it. Those who subscribe the website, it is complimentary, free of cost for the subscriber registered user. Right, and do let me know for further assistance. And we have excellent recorded videos, so you can see that videos as well. This is a recent picture. The last week in Dubai, we had one meeting with the doctors. This is my clinical experience. Dr. Arti, going very quickly, she is a consultant pediatrician taking all lectures of pediatrics. Dr. Maddie, she is internal medicine and brilliant speaker and coach and mentor, mainly concentrating on cardiorespiratory and this. I guess she's taking the endocrinology as well. Dr. Ankit, who is a gastroenterologist, who is a brilliant speaker, will come soon on board from this month. Dr. Shikha, based at Dubai, she is a consultant gynecology. And recently, three doctors joined. Dr. Mariam Hilal from US, New York. She will gonna give you the orientation and important MCQ discussion of neurology. Dr. Sonal is working in a reputed hospital in India as an emergency in charge, and Dr. Ismail is also there. These are the few recent pictures, recent, very recent, just few days back. This is myself, and we have a lot of doctors. We had a get together last week in Dubai, probably the last Sunday, I guess. So we had excellent meeting with many doctors came from different parts of Dubai. So we had a nice discussion and little debate. This is hard copy book we recently launched new. This is the latest updated version is now soon in market, probably in a 1 week. So if anybody is interested getting the hard copy book, there are lots of discounted various packages are also available, which gives you discount up to 50 to 60, 65%. So you can later inquire data flow services. This is the data flow services. So you can also inquire. And recently we are launching the dental course as well, right? So dental course we are launching soon. So, and this is the package various. We usually recommend 40 hours coaching, which is a 3 months unlimited subscription and 40 hours of coaching, which is more than enough for you to crack the exam. And the cost is like from 900 to 1000 to just 350. So that would be extremely cost effective as well. This is our mobile application on Android and iPhone, right? So Apple, so you can use that for applications as well. And this is Android. And you can completely see our website from the mobile application. So whole website now can be accessed with the mobile application. And last but not the least, then we'll jump to the questions. I have quickly researched some point why people cannot crack the exam, though it is not related with the exam, but 110% some point probably will be related to you. Right, so unauthentic study material, because we are not having with the study material good, so we are going on Facebook, Instagram, various social media platform, and we'll try to get it. But unfortunately, most of the time it does not work because of lack of answers, explanations, discussion, reference, pictures, ECGs. Nothing is there. So they have just question answer, probably right or wrong, don't know. There is no mentor from day one, so you are in the blank, right? You don't know what to do, what not to do, how to prepare, what to prepare, what not to prepare. So if you have a mentor from day one, you're gonna definitely have a good time in preparing for the exam. Lack of time management is extremely important. I've seen many doctors, right? They don't have time management. End of the day, either, I mean, they end up with a failure because they are unable to manage time before and after during exam. Lack of everyday's timetable means you need to make some fixed timetable for yourself, what exactly you gonna do, right, in your day-to-day practice, how you gonna start your day, how you prepare the things and everything, right? So this is very, very important things for us to make a timetable. Timetable is extremely important. Those who did not make the timetable, I urge and I request you to make a timetable, right? If you make a timetable, your life would be very, very easy, believe me, right? So that's it. This is what the time regarding the timetable as well. So, right, taking premature dates. This is also important. Premature dates means people are taking date in advance, right? I mean, they think that they can crack it easily, but don't take it. Otherwise, it's not a cup of tea. Right now, the DHA, the MOH, or whatever exam PROMETRIC Gulf you're giving, it's absolutely, I mean, getting little tougher. What I'm saying for last 10 years, the complexity they are gradually increasing. So it's never a one-liner question. You need to prepare well thoroughly. And as I told you, I mean, if you are a full-timer, you need to prepare well. Full timer, they can prepare 3 months time frame. In general, 3 months time frame is good enough for them to crack the exam. And those who are full timer, they can crack the exam, right, probably in 2 months, right? So this is what I usually give, right? So full timer is a 2 month, and preparation time is 4 to 6 hours a day for full timer. Those who are doing job 3 months, at least 3 hours. For full timer 200 MCQ a day, quality MCQ a day, and for part timer at least do 100 to 150 MCQ a day because you are doing some job, blah blah. But believe me, time is not important. Important how you prepare for the exam, how much you prepared yourself for the exam, how sincere you are about your exam. Right? Get out of the comfort zone. People are in comfort zone. Oh, I have enough time. I have a lot of time. I will do it by my own, right? So get out of the comfort zone. Excusitis, stop doing excuses for yourself. Sincerely give 1.5 month. I will assure you 100% you're gonna crack the exam. Don't be overconfident or underconfident. That is also a problem. And lack of dream. So if you have no dream, you cannot achieve it probably. So that is the number one motivating factor. So that's all. I mean, this is what students are keep asking me how to do, what to do, why I cannot crack the exam. So I recently added this slide by my experience of last 10 years of coaching with ProMetric and all Middle East exam. So I mean, you keep in mind there must be long list than this as well, but this is the general list, probably one or two, this 1 to 10 maybe relate to you. So just keep in mind whatever is there, try to discuss with me, and let's start with the next our the main core of the things. If uh, just when you are not speaking, I request and urge you to stop, I mean, mute your mic. You can unmute anytime. We'll discuss it. We are not here to mug up the things, absolutely conceptualize. And I can 100% guarantee you, if you listen me carefully, lots of concept clarity would be there down the line, right? So first question in front of your screen, right? Identify the cell given in picture. What's the history? History is middle-aged man presented with splenomegaly and pancytopenia, monocytopenia, did a bone marrow biopsy for the pancytopenia and bone marrow biopsy aspirate shows this picture, and unfortunately that was dry tap. What is the most likely diagnosis as well as treatment? So you have acute myeloid leukemia, chronic myeloid leukemia, acute lymphoid leukemia, chronic lymphoid leukemia, HCL stands for hairy cell leukemia. So what is the diagnosis? So let me, you think over it. I'll give you enough time for thinking and all. right? So you have a triad with you. Triad means like you need to know the three things, right, in every MCQ, right? What is the diagnosis, what is the treatment, and what is the investigation. So you need to make first diagnosis, then you need to know what is the investigation of this scenario and treatment. So this is what the triad is. So you think over it, what it could be, and then we'll discuss. This is open. Don't worry about what people are saying for you. It's a silly questions. No question is a silly question. Open up yourself, ask even basic of the basic questions. I would be glad and happy to answer you. So don't worry about asking the question. Yes. Now we have a chat box. Those who are little shy to answer, there is a chat box. So you can post A, B, C, D in the chat box. So let me ask Dr. Atulya, if you can interact with me, why do you think it is a AML? Yes, Atulya.
So with the age, one.
Okay, so let's I will give you the learning point. This is absolutely high yield all tips I'm gonna give you. So you need to just keep in mind, right? So whenever you give any answer, say for example AML, so we need to figure out, right, point favoring and point not favoring, right? Because this is how we learn, isn't it? Yes or no? Right? So I will add one slide here and I'll gonna okay, so here you told me AML, right? So let me write down the point favoring AML. On scenario, what point favors the AML? What point favors your answer? Right? So I'll back to the slide, right? So now tell me what thing makes you to think of AML? Tell me. One, you told me age, right? So middle age. So let me tell you, or let me, I mean, debate with you. So in middle age, you also can see many a times CML. CML can be seen in a middle age. AML can also be seen in the middle age. Sometimes, I mean, most of the ALL patients are pediatric patients, but I have seen in my 22 years of clinical hematology practice, there patient coming at 40 years of age, 50 years of age, even 60 years of age ALL. Though it's less common than pediatric age group, but they do also present with this, right? So go ahead. I mean, this is absolutely brainstorming from everyone. Any comment would be highly appreciated, right? So one by your sense is the age, right? So what else apart from age? I'm just trying to understand. As I told you, this is learning platform, so we'll not mug up any answer. We'll understand each and everything. Yes, Akhilya. What's the second point? Only age. I told you the something related with the age. Only age favors AML or any other things by your sense favors the AML.
The picture shows a or road.
Okay, so where you see the OR road? I cannot see the OR road. Can you help me to just figure out where is the OR road? If I can say this is right upper, right lower, left upper, and left lower, where you see the OR road? Where is the cytoplasm? Where is the OR rod-like structure in the cytoplasm? Yeah, OR rod is a AML. That you are right, OR rod, but we cannot see here OR rod. Our rods is AML. Any other point? Do you see the massive splenomegaly or splenomegaly in
Yes,
AML?
yes.
You see, okay,
Splenic.
you see usually a dry bone marrow or dry trap of the bone marrow. Have you ever seen the bone marrow? How to do the bone marrow? Or have you seen the bone marrow procedure? If you have not seen, I have an excellent video, right? Thousands of viewers. So you can see that bone marrow from step 1 to Z, A to Z, how to do the bone marrow. Step-wise completely presentation on my YouTube channel. So you see later on. Anybody wants to say any comment? So this is not a OR rod, doctor. This is not OR rod. I'll show you the OR rod, how the OR rod looks like, right? So I'm not in favoring the AML. So AML, what usually is seen, the how the AML is seen, middle-aged or elderly people, number one, they have pancytopenia, they have hypercellular marrow, bone marrow usually hypercellular, right? Usually no dry tab, usually no dry tab, usually no dry tab. Here they are saying dry tab. In AML, usually less likely you see the splenomegaly. See, but less likely splenomegaly. And the picture they have mentioned is absolutely not of AML. Or rod is what? This is a cell, this is a nucleus, right? They have the cytoplasm, and there is a rod, absolutely rod-like structure in the cytoplasm. This is or rod. This is or rod. It is not a or rod. Absolutely, this is not a or rod, right? So this is not a or rod. Yeah. So what is the second thought process in the audience? We are more than 30 doctors so far joined. So I would like to understand your concept, how you gonna differentiate it.
Hairy
This
cell
is
leukemia, sir.
hairy cell leukemia. Excellent. So let's discuss the hairy cell leukemia because we have 5 things to discuss in every MCQ. As I told you, so if you are saying me CLL, we'll discuss CLL, right? So your answer is hairy cell leukemia. Now give me the point favoring the hairy cell leukemia. Same exercise we'll do for every question. And if you cultivate this practice, believe me, no, you are unstoppable in MCQ. Nobody can beat you because we need to rule out all. Now I will rule out AML. Why not AML? Right? There is no OR rod. We cannot see any OR rod. Number two, there is no blast, no increase in the blast cell in blood and bone marrow. Definition international is more than 20% of the blast cell in peripheral blood or bone marrow is a AML. So as doctor rightly said, OR rod. So write down here OR rod is equal to AML, but here no OR rod. So here I'm not thinking of AML, right? So AML is equal to A or rod and or rod is equal to. So in any scenario, it is a very high yield question. They will give you the or rod picture and they give you scenario like this and they ask you what's the diagnosis. If you have or rod since then it is AML. And when you think of AML, look at the two things, one or rod and more than 20% of the blast in peripheral blood or bone marrow, which is not here. They had not mentioned anything about these things, right? So AML is out of the way now. Hairy cell. You told me hairy cell. So now tell me what point favoring the hairy cell leukemia.
The first thing is like the cell looks like having cytoplasmic projections.
Excellent. So one is this is a cytoplasm and outside the cell there is a hair-like projection, right? So this
Yes,
is
sir.
hair-like projection which you can see under the microscope. So this is 1 point favor.
Sir, splenomegaly will be there.
Wonderful. So splenomegaly will be there, pancytopenia will be
Cytopenia will be
there,
there.
monocytopenia would be there, bone marrow is usually dry,
Dry, yes, sir.
right? So these are the classical. So this is hairy cell leukemia. And apart from this, right, hairy cell leukemia,
Yes, sir.
this is a classical presentation. Can anyone tell me what are the other causes of dry tap? So when you do the bone marrow, but nothing comes, bone marrow aspirate is dry. One is hairy cell leukemia. What else? What is the another
Aplastic
common?
anemia.
Usually not.
Aplastic.
Aplastic anemia is not because aplastic anemia, let me tell you, sir, aplastic anemia is a reduction or reduce the this production of the blood cell, all erythroid, myeloid, and megakaryocyte, and that is why you get a pancytopenia. But if you do a bone marrow is not dry, usually not dry,
Okay.
because I do everyday bone marrow for many of my patients, leukemia, lymphoma, myeloma, aplastic, MDS, and long list. So rarely I get, yeah, the cellularity is low. So don't get confused yourself. Hypocellular and dry tab. Hypocellular is not dry tab.
The
Hypocellular,
myelofibrosis, sir.
right? So hypocellular means, let me give the concept first. So when you aspirate, right? Aspirate is good, but if you see under the microscope, the cellularity is less. That is called hypocellular, right? So hypocellular is different from dry trap. It's so don't get confused. Another important is myelofibrosis because bone marrow is completely replaced with the fibrofatty tissue. Myelofibrosis comes under the classification of myeloproliferative disease. There are four subtype of myeloproliferative disease. One is a polycythemia vera, another is CML, chronic myeloid leukemia, third is essential thrombocytosis or essential thrombocythemia, and myelofibrosis. So these are the four things come under the myeloproliferative disease. One of them is myelofibrosis, where you're gonna see why, because complete bone marrow is replaced with the fibrous tissue. When you do the aspirate, nothing comes out. That is called as a dry tap. And many a times you have a metastatic disease in the bone marrow, right? So breast cancer spreading to bone marrow, right? Any other this solid organ or solid tumor can spread to the bone marrow. So many a times I get a dry tap, right? So these are the few conditions where you're gonna get the dry tap in this such a patient, right? So now, doctor, can you tell me, right? So this is not AML. Why not ALL? I'll give you ALL. This all things you must know. If you know the clinical things, how do they present the your job is very easy. So what? So point not favoring here is what, right? No dry tap usually. You cannot see no or rod, right? No blast cell. That's it. No increase in the blast cell. If they have mentioned more than 20% blast, the probably the picture would be different. And when something is not mentioned, means it is normal or not there. ALL, acute lymphoblastic leukemia, usually seen in a children or pediatric age group, right? There is a hepatosplenomegaly, not just the splenomegaly. Usually you see, right? You see the lymphadenopathy as well. You usually do not see the dry tap. There is no dry tap. There is a lots of material and there is a hypercellular marrow, and again no increase in the blast cells, no increase in the blast cell. So leukemia, the basic concept or basic definition of leukemia, right? The two things, right? There is acute leukemia and chronic leukemia, right? Acute leukemia definition is more than 20% of the blast in blood or bone marrow is acute leukemia. Chronic leukemia, there is no blast cell, usually no blast cell, right? I'm giving you the head-to-head very important differentiation point. This is the most, only one line for acute versus chronic. When you are labeling any patients now onwards in your practice as acute leukemia, you must look at the more than 20% of the blast in blood or bone marrow. If it is there, it is acute leukemia. Acute leukemia have two entity, acute leukemia, acute leukemia. If you have myeloid origin, it is acute myeloid leukemia. If you have lymphoid origin, it is acute lymphoid leukemia. Here you see more than 20% of the myeloblast, and here see more than 20% of the lymphoblast. So this is what you can see under the microscope, right? So this is the basic differentiating point. There are a lot of points to discuss, but as of now, I mean, stick to this MCQ. You need to know the basic thing. CML, usually what the presentation is, it can be in the middle-aged patient, yes. There is a massive splenomegaly, usually high count, increased total WBC count, no pancytopenia, no pancytopenia. There is no pancytopenia. So you see the patients, 95% of the patient present with middle-aged man comes to the early satiety, mild upper left quadrant pain, right? High WBC count, platelet count is many a times increased. It's a part of myeloproliferative. So proliferation of the platelets as well. So thrombocytosis is also there, right? So increase count here, what they are saying, not increase count. They are saying pancytopenia means low HB, low WBC, and low platelet. That is called as a pancytopenia. I am saying in CML, WBC is increase, not decrease. So it is against it. Splenomegaly could be there, right? But there is an increase in the count. And you cannot see the picture like this. You can see all the cells of the bone marrow in the blood. Myelocyte, metamyelocyte, band cell, right? So all premature cells, you can see. Why not CLL? CLL is a disease of elderly people, not middle-aged people. Usually you see after 60, 65, right? There is a lymphadenopathy. There must be a hepatosplenomegaly, increased number of the lymphocyte and more than, right? If you know the lymphocyte, right? Normal neutrophil in blood is 60 to 70%, and lymphocyte is around 30 to 40%. You got it? So lymphocyte is absolutely increased, absolute lymphocyte count is increased, and this is called as a CLN. And hairy cell leukemia, middle-aged man, pancytopenia, dry tap, hair-like projections on the cells of the surface, right? So this is none other than hairy cell leukemia. So diagnosis has been done now. Now, can any gentleman can tell me what is the best initial test for hairy cell leukemia and what is the confirmatory test of leukemia, hairy cell, and what is the diagnosis and what is the treatment of hairy cell leukemia? They probably ask you the treatment as well. It's not, I mean, they're gonna ask you what I'm going to teach you. They can ask you, and that is why keep always the success mantra is this triad. Now onwards, any MCQ you come across, you need to ask yourself, what is the diagnosis? How you gonna investigate this patient? How you gonna treat this patient? So if say, for example, one MCQ you are solving means you are solving 3 MCQ. If you are solving 100 MCQ a day, you are solving 300 because you are asking 3 questions. Hairy cell leukemia, here 3 questions. What is the diagnosis? You know. How you investigate? You know. How you treat? You know. So you solving 3 MCQ. Minimum 3 MCQ. We are discussing hundreds of MCQ in 1 MCQ, but at least 3 you can answer. So this house is open for all. How you gonna, if I can ask you, now you have a patient of suspected hairy cell leukemia, what is the right based initial test? These are the all glitch in the sentence, right? So the scenario is same, but if you need to concentrate in the exam, what is the best initial test? What is the confirmatory? Yes, I'm coming to you, doctor. So, best initial test, it's a different answer. Confirmatory means highly specific, sensitive, 100% sure that by doing positivity of this, you are confirmed that this is hairy cell. So, the gentle lady asked the peripheral smear. So, peripheral smear is the best initial test, right? Anybody wants to comment on this or some other test or peripheral test is the, I mean, investigation of choice or initial investigation. When you suspect anybody has a hairy cell leukemia, is it the investigation you or you have something else in your mind for initial test?
It's the fact that in the question they have already mentioned the bone marrow,
Sir,
it should dry.
can you make your mic little closer, sir? Sorry, I cannot hear you clearly.
The fact that in the question they have already mentioned about bone marrow, that means the bone marrow is done. So I'll go with flow cytometry.
Excellent. So flow cytometry you want to do for confirmation, right? So this is
Yeah, I think
yeah. Great. So let's come to the literature, right? We will discuss each and everything with the literature. We'll not just going and speaking. We need to have some strong backup. Hairy cell leukemia. Hairy cell leukemia is a middle-aged man. So one criteria we have a first line in our scenario is a middle-aged man presented with pancytopenia. Second, presented with the splenomegaly. Third, monocytopenia. Four, tri-tap. Five. Everything is there in our scenario. Middle-aged man, pancytopenia, splenomegaly, monocytopenia, right? So if you want to go back the things, everything is there in our scenario, right? Middle-aged man, splenomegaly, pancytopenia, monocytopenia, dry tap. That's it. So this is more than enough. In right smear showing the hairy cells in a best initial test. So you already mentioned it's a hairy cell is like you can see the hair-like projection, right? So hairy cells, and that is how the name comes. So best initial test, if somebody asks you best initial test, immunophenotyping by flow cytometry is the most accurate test. And what you gonna see in immunophenotyping, right? CD stands for cluster differentiation. 11C you can see, all right, presence of CD11C is the pathognomonic or it's a diagnostic point of hairy cell leukemia. So we have seen how to do the diagnosis. We know now the what is the initial investigation and based investigation, and now we need to know the intra treatment. So treatment is cladribine or pentostatin. This is the drug of choice in hairy cell leukemia. B cell is filamentous projections are seen on the smear, right? So this is a cell, and now onwards you look like properly. This is a filamentous, so it's like hair on the cell, hairy cell. So like looks like how you differentiate from the or rod AML. This is nucleus, nucleolus. There is absolutely rod-like structure inside the cytoplasm, nothing outside inside the cytoplasm. Here it is normal, nothing inside the cytoplasm. Hell-like projection. Is that clear to everyone? Yes or no? At least tell me yes or no.
Yes, sir.
Wonderful. So
Yes,
I
sir.
think I am clear.
Yes.
I'm giving you 10 minutes space to ask any question with AML, ALL, CML, CLL or HCL. If you are not asking me the questions, I take it granted you understood all well. You all are brilliant. I'll go ahead. Take 10 seconds. Any questions? Anything?
Bone marrow biopsy will not be confirmatory test, sir, in this?
It is a diagnostic test. For diagnosis, doctor, any diagnosis, say for I want to diagnose AML, ALL, CML, CLL, hairy cell, or any leukemias especially. Bone marrow is usually the diagnostic test, not the confirmatory test. What happens? Why not confirmatory? Because this is the clear-cut picture, but many a times what happens? Say I am doing bone marrow. I forget about I want to know whether it is AML or ALL. Example for your understanding. This is nuclear, right? And OR rod is not 100%. OR rod is mainly seen in AML subtype M3 or acute promyelocytic leukemia, where you can see highest number of cells or OR rods in the cytoplasm. But it is not mandatory that if OR rod is not seen, means it is not AML. Without OR rod, you have to have AML. So sometimes under the microscope, it is difficult for you to differentiate whether it is a myeloblast or lymphoblast. You can say, oh, this is acute leukemia, confirm. I see lots of blast cell in, but I cannot differentiate myeloid blast versus lymphoblast. And for that, you need to do, there is a markers, this is called on the surface of cell, called as a CD, cluster differentiation. So there is a myeloid CD marker and lymphoid CD marker. So you can diagnose with the immunophenotyping or flow cytometry, right? So this is flow cytometry is the confirmatory test of almost all leukemias, which gives you the diagnosis of genetic makeup of the cell, whether myeloid, lymphoid, or other cell. Is that clear? So bone marrow biopsy is the diagnostic test, right? But here they ask the specific thing, confirmatory test. Then it is flow cytometry. Is that
Okay,
clear
sir.
to you, doctor?
Also.
Yes, sir. Thank you, sir.
No worries. Fine. So I think there is no lot more questions on this. Let's come to the second questions. I'll gonna give you tips as well. A 61-year-old man comes to the physician for an examination prior to a scheduled cholecystectomy. He has hypertension treated with a hydrochlorothiazide. His mother had a chronic granulomatous disease of the lung. He works in a glass manufacturing plant now. He has smoked 2 packs of cigarette daily for 38 years. His vital signs are within normal limit. Examination shows no abnormality, right? So basic blood workup is reasonably normal. Laboratory studies are within normal reference range. An X-ray of chest is shown. Which of the following is most appropriate next step in the management, right? You perform arterial blood gas analysis for this client or patient, perform CT guided biopsy, perform DLCO or pulmonary function test, measure angiotensin converting enzyme level, perform high resolution computerized tomography or CT scan. You also request for previous chest X-ray, perform PET or PET CT scan, or you repeat the chest X-ray in 12 months. So probably this X-ray is small, I know. So I'll give you this bigger X-ray. This is bigger X-ray, probably the same X-ray, but I'll enlarge it for you guys. So just to have a little more insight, they will not give any arrow in the exam, but I had given the arrow in the exam. I mean, for your little, make your job easy, right? There is some kind of nodule seen in the periphery of the lung, right? They will not tell you in the exam, but I'm telling you just to get a better clarity. So some kind of here the peripheral nodules you can see. The rest of the lung examination is apparently clear. Upper, middle, lobar lobe, costophrenic angle clear, cardiophrenic angle clear. No effusion, no pneumothorax, no hemothorax, no shift of mediastinum. No much looks like a tuberculosis. There is no mediastinal lymphadenopathy, just for your knowledge. So looks fine except this peripheral, this lesion in the lung. So go back to the questions, think over it, right? What it could be, and you give me the answer with the explanation. I will ask you the why. Just keep in mind, whatever you answer, I would be happy. We'll discuss each and everything in detail and try to sort out one by one why this not. Our job, right, while doing the MCQ is not just to give one answer. Our job is to differentiate why not other answers, why not this, why not this, why not this. That is a analytic skill. It is a clinical skill. So that you need to develop, right? And we will develop definitely. And practice is the only key to success. Yes, anyone wants to have any comment on this? What's your thought process? Or if the same patient comes to you in your exam, what you gonna tick for this patient? What's your answer? These all exam questions only. I got it from past papers, but make it in a more presentable way. Yes, so Lalita is saying silicosis. So what you want to do? Say for example, it is silicosis. So what you want to do for silicosis in this patient? How you gonna forward? How you gonna go ahead for this? Most of the people are saying high resolution computerized tomography.
Yes,
So yeah, so let me ask you why you want to do the high resolution this CT scan, Dr. Sandhya. Any comment on this? Yes, if you can able to answer, I'm happy. Yes. If you forget the trial, it's trouble. If you do not forget the trial, happy. This trial is not in the book. I created by my own, by my experience. If you know these three things, then 90% of the syllabus is covered in your exam. Whatever the exam, when you are giving USMLE, MRCP in future, if you know these three things, you are 99% done, because either they ask you diagnosis, investigation, treatment, stress management. Yes, Dr. Lalita, Dr. Sandhya, any comment I want to hear from audience. We are more than 40 doctors so far now. And comment is only 2 to 3. So don't think that this will not come in your exam. It will definitely come. You need to stretch your mind and neurons. Why this not? Yes.
Having chronic convulsive.
Sorry, ma'am. Can you speak it little?
So the family history.
Okay. So
Mother has
first of all, tell me, doctor, what's your diagnosis? So we'll discuss on that point, na? And it's a learning for everybody. So what do you think? What is the diagnosis? Just follow this pattern. 1, 2, and 3. Go by this way, so you never go wrong. Believe me. So what is the diagnosis, or I can say differential diagnosis, or most likely diagnosis from this scenario? What can you make out? Because they are not given the clear-cut diagnosis in this case. There is some kind of peripheral nodule, and this is the history. What could be the diagnosis? Yeah, because it's important. How can we jump to the management without knowing the diagnosis?
it will be an interstitial lung disease.
Okay, it's an interstitial lung disease. Okay, fair enough. So interstitial lung disease. So do you see the nodules or peripheral nodules in the interstitial lung disease, or you see in some other condition? Now tell me, what is the radiological presentation of interstitial lung disease? This is all important. If you don't know, you need to go and read it properly. How you differentiate by X-ray interstitial lung disease, tuberculosis, lung cancer,
Ground glass
COPD,
appearance.
ground glass appearance. So what ground glass appearance suggests what? If you have a ground glass appearance on X-ray chest, what's the differential diagnosis? Tell me, 1 to 5. Ground glass opacity, fine. What are the 5 differential? No? In medical science, there is not only one thing which is right. There are 5 minimum headache. You have 5 differential diagnoses. Chest X-ray opacity, 5 differential diagnoses. Like costophrenic angle altered or obliterated, 5 differential diagnoses. This is what you need to do the practice. Anyway, any comment?
I think, sir, this is silicosis, sir.
Okay, so now let's discuss silicosis. Whatever you tell me, silicosis.
Because in, exposure like glass manufacturer habit plant.
Okay,
One thing, and
glass manufacturer. I'm writing down, sir. Glass manufacturer in the history. What else?
and next thing, sir, left upper lobe injuries. I think there is one
Where
back
is the
injury.
left upper lobe injury? It is mentioned. Where is the left upper lobe injury?
Uh, left
This?
upper lobe. This no,
Yeah,
sir.
yeah.
In X-ray, sir.
X-ray, what you see in the silicosis? What is the classical finding in silicosis on the X-ray?
Excel classification,
Sorry,
sir.
what? Sorry.
Excel classification.
Okay,
Excel.
I got it. I got your point. Excel. So do you think
Yes,
this
sir.
this
No, sir.
picture,
I
the
think no.
solitary only nodule and rest of the complete lung is a normal in silicosis? Do you think so?
Yeah.
This is the case. And this patient is fine. Now, what is the problem with the patient? He's an elderly man, right? 61-year-old man. Right? Man comes to the physician for examination prior to a scheduled cholecystectomy. So this patient probably has some gallstone or whatever the reason, he need to go for cholecystectomy, and that is scheduled or planned one, not emergency one, right? He has a history of hypertension and treated with a hydrochlorothiazide, that is a thiazide diuretic drug. We'll discuss later on. His mother has a chronic granulomatous disease of the lung. He works in a glass manufacturing unit now, right? He has a smoked a 2 pack of cigarette for last 30 years. So you can't think of some kind of malignancy with solitary nodule in the lung. You cannot think of, right? What is the risk factor of lung cancer? Tell me, anyone tell me. These all are the exam question. Though I am giving you
Smoking.
one question, but I am trying to solve 10 question and all will come in exam. Believe me, you'll remember me. Yes, so lung cancer. So lung cancer, what is the risk factor for lung cancer?
Smoking.
Smoking.
Smoking, wonderful. Number one, smoking.
More
Can
than
anyone tell me what is the amount of the smoking?
pack year.
How
30
much
More
pack
pack?
than
years.
pack years.
30
More than
pack
10 years.
years.
How let me give you again MCQ 5 pack, 10 pack, 20 pack, 30 pack, or 40 pack. How many pack?
30 pack years for more than 15 years.
Okay, 30 pack. So I mean,
No, sir.
mostly
Two
right.
pack years more
Uh,
than 10 years.
so
Two
whatever
pack years more than 10 years, sir.
I will check out. But what I know, I deliver thousands of lecture as per the Master the Board and other book, 20 pack, right? And more than this 20 years. Age is again a risk factor for lung cancer. See, more than 55 or 60 age, here 61 age. So age is a risk factor. Patient has a right strong history of smoking, right? Patient has a long history of smoking, and there is a peripherally located this lesion on the lung. So it could be a lung cancer, right? This is what most likely it fits into this scenario. So now you tell me this is a suspected case of lung cancer. Now what you wanna want to do from A to H?
Okay.
Your homework is to read the one silicosis homework. If you don't know, how three things only. Any homework I
CT
give
guide
you,
biopsy.
diagnosis, investigation, and treatment. You need to know. So silicosis, you need to know. Yes. Someone was answering me the question. Sorry, I missed it. Yes, please. Open for all. Comment. You have a
So,
suspected case of lung
CT
cancer.
guided biopsy, sir.
Biopsy. Okay. So obviously biopsy is a good idea to go for, right? But they are asking appropriate next step in the management. So let me remove this. Arterial blood gas is not important at this time. This is a potential this answer. CT guided biopsy. DLCO is not required at this time, so we'll remove it. This will not help now at this point of time. High resolution CT scan, probably this could be answer, but we'll see. Request a previous X-ray, extremely important. PET scan is not required. PET scan is meant for the staging workup, how far the stage, I mean, disease goes from the lung. So out of the lung, liver, lung, bone, brain, opposite lung, or any parts of the body, whether it is spreaded or not, you do whole body PET CT scan. It is done for staging. So before diagnosis, staging is not much important. So you first need to make a diagnosis, which we are struggling now, and repeat X-ray in the 12 months. It's not appropriate because you see some kind of opacity. You need to do for this opacity. So this is not an answer. So this is not answer. This is not answer. So probably you have a perform CT scan biopsy. That could be one answer. Then you triage, right? This is how you have to do in the exam. Perform high resolution CT scan second, or request previous chest X-ray. So now you have three answers for this. Now, what you want to do, or what do you feel that this would be the most appropriate or most appropriate next step in the management? Though it is little tricky, but it's important, and this is how it comes in exam. It's not a one-liner lollipop questions for you. Yes, anybody? Any comment?
So this patient is going for a scheduled cholecystectomy.
Yes, yes, you are right. He is going for scheduled cholecystectomy, nothing urgent. No? Scheduled cholecystectomy is written here. Yes, so what do you think? What is the next thing for this patient? Most appropriate.
Sir, I think doing biopsy would be
From
Yeah.
perform CT guided biopsy.
CT scan.
Okay, so one is a CT scan. So can you tell me why, Dr. CT scan? What information you're gonna get from CT scan? Sorry, I cannot
Appreciate
see.
the tumor in the CT scan.
Okay. You are Dr. Akinola?
Dr. Ashna.
Oh yeah, sorry, I'm a lot of doctors, so I can't see exact name on 50 names. Fine. So sorry, can you speak little louder? Why do you think that there is a CT scan needed, not CT scan biopsy? I'm saying X-ray is important because this is the first time you are seeing the opacity on the X-ray. So if you have old X-ray, you can compare. So what do you think?
Biopsy is more invasive. I
Yeah,
think that before performing such an invasive step, we would probably go for something which is less invasive. So
true,
I would
absolutely.
probably go for a high resolution CT scan here to
Excellent.
see the tumor lesion on the CT scan.
Wonderful. When you have options of repeating the previous, if the patient has a previous X-ray, is it important to get a previous X-ray and compare it and match it, whether this is new lesion or old lesion, or any progression of the old lesion? Does it make sense? What do you think? If you are in the round,
No,
you
sir.
have the same
He's
X-ray
working
and
in
same
glass
patient.
manufacturing plant.
Right.
So there will be previous X-rays available.
Yes. So that is there in the option.
So we
Request a previous chest X-ray or perform high resolution CT or perform biopsy. So let me give you the idea. I am removing these options as well because it's more invasive, and before doing it, we need to confirm it. So now you have two options, high resolution or X-ray. We narrow down from 8 options to just 2 options. Out of these two, yeah, I'm glad to discuss. Yes, any comment?
Even if we
because
compare it with
previous
the previous X-ray, we would still have to go for a confirmatory investigation, and that should be the CT scan.
So it will be
So
HRCT, sir, for more precisely.
yeah,
Fair
so I
enough.
think the HRCT should be the next most appropriate.
HRCT.
Yeah, it's a little tricky, I know.
Yes, yes, yes.
Yeah. Fine, fair enough. So majority of the house is saying HRCT, right? But here the answer is X-ray, not the HRCT. Now let's discuss. Don't worry. I mean, it's a learning platform, so we need to discuss. It's not like that. So patient has a, what is the patient having? You must be remembering that X-rays as well. So there is a peripherally located solitary pulmonary nodule. This is the lung. And if you remember the X-ray somewhere here, they have a peripherally located, solitary means one, single means solitary, single pulmonary nodule on X-ray. This is what the finding on the X-ray. Just we narrow down to two answers, either X-ray or high resolution. Right. So let's little discuss and understand what exactly, I mean, how we supposed to think and how we supposed to do in the clinical practice. So high resolution CT scan can be useful in the diagnosis of restrictive lung disease. This patient's occupational history of glass manufacturing puts him in a significant risk of silicosis, which can also manifest with a solitary pulmonary lesion. However, patient with this lesion typically present with the dyspnea upon exertion, productive cough, and X-ray finding such as axial calcification or bilateral ground glass opacity, which are all absent here. So now your queries is solved very clear cutly. I would be happy to answer if you have still queries. So if you are suspecting this patient as a silicosis, right? Apart from this single nodule, what else you should have in the X-ray, right? Or on the CT scan, if you, right? So nothing on the X-ray, right? Or if you can see, right? Solitary pulmonary lesion. Patient does not have dyspnea upon exertion. Patient doesn't have the productive cough, right? Patient doesn't have the axial calcification. Patient doesn't have bilateral ground glass opacity, which all are absent here on the X-ray. So high resolution CT scan is a second step, not the first step. What is the first step? Requesting a previous X-ray is the most appropriate step in the management of the patient with a solitary pulmonary nodule, especially when the risk of malignancy is high. And this patient is absolutely at the high risk of malignancy. What point favors the high risk of malignancy? Age more than 60 years, history of heavy smoking and long smoking. Old imaging studies are used to assess for new changes on the current radiograph, additional nodule, what is the size of the nodule, right? Enlargement or what is the progression of nodule, all can be. And let me add two more things. X-ray is one of the most easily available X-ray everywhere in the world, and it is most economical as well. So there is no harm doing the X-ray, no harm doing this USG in your patient. It is not mandatorily that you need to jump on the test. You should go, but go step by step, go step by step. All right. And probably many centers, even in India or outside, I've seen in even Middle East country, very few hospital have CT scan. And yesterday I was asked for one MRI for one of my friend yesterday. Appointment of 6 p.m. He got a MRI done at 9 p.m. They waited at 3 hours at the center just to get MRI, right? And they have to travel almost 1 hour in Dubai only, 1 hour in Dubai. Every center does not have it, just for your kind knowledge, I'm telling you. So go with the test which is more important, more easily accessible, more sensitive, right? And which gives you the idea. So in the context of this question, right, chest X-ray, right, is the most important thing. And they have mentioned one, following the review of the previous imaging or X-ray, or if the no X-ray is available, if patient say I have no X-ray, this is the only X-ray. In that case, low dose CT scan is indicated to assess the nodule size, location, and signs of the malignancy. Once you confirm on the CT scan, right, then the next appropriate step, second question, is a CT guided biopsy. Once you do the CT guided biopsy and you diagnose it as a non-small cell lung cancer, then you go for the PET CT scan for the staging purpose. And once you do the PET CT scan, you do the staging, which stage it is. On that, you can either go for chemotherapy or surgery or chemoradiotherapy or some kind of targeted therapy, or you can go for the immunotherapy. That's it. This is what and how it works in the clinical practice, what we are doing in day to day. So we do the X-ray, right? If they have the earlier X-ray, well and good. If they don't have, jump to the CT scan. CT scan suggests you of nodules or malignancy, history, physical examination, radiological. You need to club up everything and make diagnosis. This is a solitary nodule which needs to be evaluated. Do the CT guided biopsy, then staging, then treatment. So this is what the answer for this. That's all for this question. So this is the most appropriate thing for this. I'll give you the literature and guideline how the solitary pulmonary nodules can be evaluated globally. So probably many pictures you cannot see in Master the Board or so, because I subscribe many international journal to make my learning very effective with take home message and make it easy for you guys. I have a lot of picture in my every presentation of the class. So this is what the schematic presentation, very nice. what is the thing? Incidental solitary pulmonary nodule on X-ray. That is what our case is. Patient did not came with the pulmonary complaint. He came with the planned cholecystectomy at the 61 year of age. So what that does mean? Incidental. Incidental. If patient has a cough and you do X-ray and pulmonary nodules, it's different thing. Patient came for the cholecystectomy and find out there is something wrong in the X-ray, that is incidental. So they are saying in the guideline, incidental solitary means single pulmonary nodule on X-ray, right? It must be rounded opacity less than 3 centimeter, completely surrounded by parenchyma and no associated lymphadenopathy. So this is first step. What is the appropriate next step? Compare with the previous chest X-ray, not CT scan. Compare with the previous X-ray. That is what our answer is. Compare with the previous X-ray, right? If no available, right? So ideally you should ask for this. If no available, then CT scan, right? What you can see, compare, you did a comparison with the chest X-ray and you see this lesion is stable over 2 to 3 years. No further testing. Here the chapter is closed. But what if it is not stable? No previous image or possible increase in the nodule size, right? Obtain a chest CT. So second is a chest CT to assess the malignancy risk. This is the next step. Compare X-ray. If not available, do CT scan. Third, depends on the size. 0.8 or a small nodule, solitary 0.8 to 2 centimeter and more than 2 centimeter. So more than 2 centimeter, 60 years of age, as we seen in upper lobe, right? High risk patient is 65 or close to 65, right? You need to do a surgical excision. Solitary pulmonary nodules needs to be removed surgically. Send it for the histopathology and depends on that you wanna do further test. This is for 2 centimeter, 0.8 to 2 centimeter, right? Intermediate risk, right? Then look at the nodule size. If the nodule size is 0.8 centimeter or more, you can go for the PET CT scan or biopsy, preferably biopsy, right? And it is small malignancy risk. Just you assure the patient, send back home, and between this size, you do the regular spiral CT scan. Regular, because patient may probably a small nodule. After 1 or 2 years, they have little large. After 1 or 2 years, so if it is keep increasing in a, two things you need to remember: more than 60 years of age and smoker, preferably heavy chronic smoker. And these two criteria, if any patient have, right? Guideline like mammogram guideline, there is a mammogram guideline. Every female more than 50 years, by many books, they need to do annually or every 1 to 2 years, they need to do a mammogram. You need to know the screening age of the, this is another huge question in exam. So cervical cancer screening, name of the test is PEP test. 21 to 65 is the age. This is one exam question. You must know it. Cervical cancer screening. Second is a lung cancer. Two criteria: 50 plus age, heavy smoker, low dose CT scan annually. You must do it annually. Third, colon cancer screening test, colonoscopy every 10 year, and age group is 50 to 75. You need to know three things: what cancer, what test, what age group. That's it. So cancer is colon cancer. What age? 50 to 50. You start at 50, stop at 75. Frequency every 10 years. Breast cancer, test of the name is mammogram. Some, right, book says like 45 young age as well, but most of the international book still say 50 years, every 1 to 2 year, right? And start at 50 and stop at 75 years. And last but not the least, PSA, prostate specific antigen for the prostate cancer. Annually, it's little controversial, but annually you can do it, right? Age limit is 50 to 75. So here you see the lung cancer. Lung cancer, what's the guideline? Lung cancer, smoker, 50 plus age, you should screen annually with low dose CT scan. This is guideline. Open the book, any book, you must see this, right? And if you see the nodule, the thing, if you have X-ray, well and good. If you don't have X-ray, you do the CT scan and do the excisional biopsy. Excisional biopsy. Excisional biopsy. This is surgically excisional biopsy. That's it. So this is what for the lung cancer. You must know it, each and everything. Your homework is the silicosis. Now this house is open for any questions. 10 seconds. Any queries in your mind? I try my level best to answer you well with the reason why it is this, why it is not this. Is that clear to everyone? Yes or no?
Yes.
I
Yes.
would be
Yes.
glad at least you reply me yes or no.
Yes, definitely.
Wonderful.
Yes, sir.
Wonderful, 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 wonderful. Great. So let's move. So this is what I'm trying to not just teach you the medical, but how the way you supposed to think for your patients, right? This everything will 100% see in our clinical practice in a day-to-day practice, right? So it is not something, yeah, you have seen hundreds of patients who come with appendectomy, prostatectomy, BPH, some renal stone surgery, and on pre-op evaluation, you see a solitary nodule in the lung. That's it. So this is what we discuss, and these all are the very high yield questions for the exam. Let's check little your cardiology. So first questions, you check your hematology and hairy cell leukemia. Second, you check little pulmonology. Now just switch the gear, change the gear from now pulmono to cardiology. Let's see how we go, right? So this is the things. I'm gonna give you the bigger picture of ECG, so don't worry. Just listen the scenario, try to understand the triad, what my triad is. If you forget my triad, then it's a trouble for you in exam. So any MCQ here I did not give, otherwise I would love to give the Munjal's triad: diagnosis, investigation, treatment, right? So keep this thing in mind and look at the scenario. I'll read it for you. 2 days after being admitted for pneumonia, 70-year-old man has repeated episode of palpitation and nausea. He does not feel lightheaded and does not have chest pain. The patient appears mildly distressed. His pulse is 59 per minute. Blood pressure is 110 per 110/60 mmHg. Examination shows no abnormalities. Sputum culture taken at the time of admission were positive for mycoplasma pneumoniae. His magnesium concentration is 2.0. For your knowledge, it's normal. His potassium level is 3.7 normal. Normal is 3.5 to 5.5. Just for your knowledge, 3.7 is normal. Just to make you the better clarity. An ECG taken during an episode of palpitation is shown here. Which of the following is most appropriate next step in the management of this patient? Right? So let me give you the little bigger picture for you to have a better understanding of the ECG. So this is a picture of ECG, but let me give you the bigger picture. So this strip, you got it at the time of palpitation, right? And they are now asking what is the best next step in the management of this patient. Can you see this strip well, yes or no?
Yes.
Wonderful.
Yes.
Yes.
Wonderful.
Yes.
So this is a strip. Just have a look at it 5 minutes, 5 seconds, 10 seconds. I would be glad. Try to make some impression, what it looks like, what is the rhythm, what is the rate, what is the diagnosis. Forget about scenario. By seeing this only one picture, spot diagnosis, what you can make. That is what the art you need to cultivate. This is the scenario. You read it scenario 10-15 seconds. I am not in a hurry. Though you won't get that much of liberty in exam, but fine, we are doing the practice, we are learning, we are in the learning platform. So I would be happy. So those who are working in emergency room, cardiology, cardiorespiratory team, cardiothoracic team, CTVS, cardiothoracic vascular team, they probably can answer. Even we can also answer, not that cardiothoracic can answer, but they probably seeing more ECG in a day-to-day practice. So what do you think? So first of all, now let's begin and make this house open for discussion. I would like to have,
It's short, sir. This point is, sir.
okay,
Torsadesis point.
Fine, fair enough. So diagnosis, somebody told torsa D pointers. Okay, fine. So what is torsa D pointers? Tell me, can you define torsa D pointers or torsa D point? Whatever the knowledge you have about torsa D point, give me 1 line, 2 line, 3 line.
It's a type of
Kind of
polymorphic ventricular
ventricular.
tachycardia.
Okay, so it's a type of ventricular tachycardia. So we can say indirectly it's brother of ventricular tachycardia, isn't it?
Yes.
Yes, sir.
Wonderful. Slash ventricular tachycardia. Okay, fair enough. So ventricular tachycardia, you come to one, I mean, just tentative diagnosis that by looking towards the ECG, it's a ventricular tachycardia or torsades pointers. Now decide any arrhythmia in your exam, there you need to ask 2 questions to yourself, not in the MCQ, in the clinic as well. So ventricular tachycardia present in a 2 way, right? Stable or non-stable or unstable, isn't it? Yes or no?
Yes,
Yes.
definitely.
Yes.
Now I want to know what is the definition of unstable VT. If I can say you, doctor, I have one patient who is unstable VT. What do you mean? What do you understand? How you define instability of the patient in arrhythmia?
Pulseless. Pulseless.
Excellent.
Pulse,
One is a
The
pulseless.
pulselessness.
blood pressure is on the lower side and it's not pulseless.
Low
It's
BP.
pulseless.
Wonderful, wonderful, sir. Wonderful. So pulseless, number one is hypotension. Let
Low
me
BP.
define the definition of hypotension. This is 110, so this is not hypotension, but we are discussing now instability. So patient is pulseless. Any systolic less than 90, fix in your head. It's not by me, it's by book. Everything, whatever I'm speaking by books. This is my more than 2000 lecture for you, right? So this is less than 90. Systolic blood pressure is anybody, any reason, hypovolemic shock, severe gastroenteritis, myocardial infarctions, cardiogenic shock, anaphylactic shock, septic shock, hypovolemic shock, neurogenic shock, means anything less than 90 systolic until proved otherwise, it is a shock or unstable. Is that clear? Yes or no?
Yes.
Yes.
Third thing which we should not forget is a neurological things. Patients oriented, not
Consciousness
oriented.
oriented.
Yeah, right. Or neurological instability is not stable. So nothing match. Patient has a pulse. Yes, very nice pulse, 60 pulse. Patient has more than 90 blood pressure. Fine. Patient does not have any neurological. Not mentioned means it's not there. So patient is stable. Isn't it? Yes or no? We can conclude that this patient probably have a torsades pointers or VT, but it is stable, sir. So far it is clear, yes or no? At least tell me yes or no.
Yes.
Yes, sir.
Wonderful. Let's move to the next. In book it is written as TDP, torsades pointer. So I'm writing short term. VT is ventricular tachycardia. So this is a stable patient. Now you can answer what is the appropriate next step in the management. Look at the options and tell me.
Administration of
Amiodarone.
One by one.
Amiodarone.
Okay, so one answer is the amiodarone. Any other answer? You give your own answer, not someone else's answer.
Immediate electrical transfer.
Sorry, sir, I'm not here. Immediate?
Immediate electrical cardioversion is suitable for unstable patient.
Yeah, but this patient is stable. We classify, that is why we discuss a lot
So
of
we
things.
will move toward the administration of myodrome.
Okay, so this patient is a stable, whether it is VT or TDP, likely VT, right? So what is the treatment of choice for this patient?
Myodrome.
Myodrome.
Wonderful.
Palm acronym.
Pacing
Wonderful.
and cardioversion is rolled out anyway.
Right. So I think somebody attended my earlier lecture. So this patient is stable. In stable patient, you remember the PALM, PALM, and unstable patient only is a cardioversion. That's it. There is no other option.
Yes.
Cardioversion. All right. So there are two indications. Can anyone tell me immediate cardioversion or DC shock we need to give or cardioversion, electrical cardioversion? You need to give
Fibrillation, ventricular fibrillation.
excellent ventricular fibrillation and ventricular tachycardia, but
VT.
important word is a pulseless VT.
Pulseless.
Pulseless VT.
VT.
VF is always pulseless. Just
Always
sorry to say, always pulseless. So we did not need to write down. VF is never a VF. Ventricular fibrillation is never a stable. You got it? Ventricular fibrillation patient is never a stable patient. So there are no two entity. If you don't discuss among yourself, I would be happy. Whatever the answer question you have, it directly asked to me. Right? We'll discuss. So ventricular tachycardia have a stable and unstable classification. Ventricular fibrillation, there is no classification. VF means unstable. Is that clear? Yes or no? This is basic, but we get confused in ourselves.
Yes.
Wonderful. Let me mute all. You can unmute, right? When you want to discuss, because now 50 doctors in the group and probably I'm getting disturbed. 1 second. Okay, I muted all. You can unmute. You have the facility on your bottom of your laptop. You can unmute and you can answer anytime. Fine. So ventricular tachycardia, stable, unstable, unstable, right? Either pulseless, BP-less, less than 90 systolic, neurologically altered or unconscious, unstable, only one option, cardioversion. Stable patient, 4 things, as I told you, the acronym is PALM. P stands for procainamide, which is not in the option, so we did not selected it, procainamide. A stands for amiodarone. L stands for lidocaine. M stands for Maxulf. Magnesium sulfate. We are not going to give the magnesium sulfate, it's normal level. Beta blocker not help at this point of time, right? Immediate cardioversion is for the unstable patients. Temporary pacing is not needed at this point of time, and administration of potassium chloride. Potassium is absolutely normal, so by adding the potassium, you cannot revert the arrhythmia. So most appropriate answer is amiodarone. Now you can unmute your mic. Is that clear? Tell me yes or no. At least tell me yes or no.
Yes, sir.
Any confusion?
Yes.
Any confusion? Wonderful. So this is how it comes in the exam, sir. So you need to remember these things, right? These are all absolutely very, very high I selected today. Anyway, every Sunday I select high yield only, but they'll still amongst the high yield, it is super high yield. So anyway, we will gonna have discussion every Sunday. So this is PALM, procainamide, amiodarone, lidocaine, and Maxulf, right? For the stable patient. So now let's jump to the gear from respiratory, cardio, hemato, now little dermatology, right? Because in your exam, you're gonna see each and everything what I'm going to present you now. So the spot diagnosis, you will love this MCQ. You will enjoy the way I'm enjoying now. Yes, this is the picture in front of you. Identify the condition and treatment. So this is a scalp, just for your knowledge. You must be appreciating this is scalp of likely male, right? Identify the condition and treatment. So scalp picture is there. Alopecia.
Alopecia. Alopecia areata.
Alopecia
areata.
Sorry, alopecia.
No. Fine. Alopecia totalis, alopecia areata,
Alopecia areata.
scabies, tinea capitis, eczema. Now you post your answer. Chat box is there. At least you post the answer so I can pick up the answer. You give your answer, not someone else's answer. Yes, Dr. Jamal. Can you comment on this, Dr. Jamal, Dr. Samar? I want you to hear.
So this is patchy area of complete baldness. Patchy involvement is there with UTI.
Okay.
Yeah.
Yes. Yes, sir. Tell me. One by one. I would be happy. One by one. What do you think in your mind? I want you to speak up, think of something, right? Not just the answer. The way we are doing it, you need to do the same way after my lecture. Yes, doctor. Anyone? Anyone have any comment?
Alopecia areata,
It's
sir.
alopecia areata, sir.
Alopecia areata, sir.
Wonderful. So answer is alopecia areata. What is the treatment? Now you have seen this patient. What you gonna give to this patient?
Intralesional
Central.
steroids.
What you want to give?
Triamcinolone.
Minoxidil.
10 mg.
Triamcinolone.
10
Okay.
mg. Every
Okay.
3 weeks.
Okay. Great.
Can give it topical corticosteroid, interregional triamcinolone. We can give interregional triamcinolone, and microneedling can be done also.
Great. Wonderful.
We will give topical injectable oral corticosteroid plus topical immunotherapy.
Fair enough. So I think you all are correct. Absolutely correct. So identify the
We can
condition.
also give JAK inhibitor also have role. JAK inhibitors.
Wonderful. There is like a ruxolitinib or something like that, right?
Yes, ruxolitinib and tofacitinib.
Wonderful. Wonderful. Brilliant.
Locally.
So this is the alopecia areata, right? It is totalis means total gone. So its total is not gone. There is a hair. So it's a alopecia areata, right? This is like a mild pattern baldness. Fine. So this is there is a well demarcated patchy area of hair loss without scarring of the scalp. Treatment options for alopecia areata. Treatment is guided by the patient's age, disease duration, extent, blah blah. But the treatment is corticosteroid intralesional triamcinolone, right? Intralesional, topical, and or systemic. And topical immunotherapy is also told by the sir. So that is also treatment. And other is a minoxidil and cyclosporin. That is also part of the treatment. So you need to know the things and treatment as well. I'm 1 minute. I mute all. I muted all. Sorry, because a lot of background chatting in between. So that's it. This is what the called as a spot diagnosis or this visual MCQ or picture MCQ. I have another one more picture MCQ for you guys. Those who answer, I need to know 12 cranial nerves name. So fix your neurons. Probably we forget how many cranial nerves and what is the name of cranial nerves and what is the functions of cranial nerves. So we'll do it today. Do little physiology of our back MBBS school days or our medical grad. But before that, you need to answer this. See the picture. Which cranial nerve palsy? Right? Optic nerve, oculomotor nerve, trigeminal nerve, abducent nerve, facial nerve. Look at the picture. Look at the options. Give me the answer and give me the reason why. That's it. Take your time. 10-15 seconds, you take it. You're gonna take it. These are the few recently asked exam questions. But I formatted it for you guys. If you shy to speak in front of people, you can post your answer in the chat box.
That is the right abducent nerve.
Fair enough. I've seen, sir, your answer, Jamal, sir. I'll get back to you. I'm just waiting for more little options. Yes, Dr. LB. Any comment, Dr. LB? Dr. Asna Asis, any comment?
Yes, it is right abducent nerve palsy because the patient is not able to laterally rotate his eye. So
Fine. So now tell me, Dr. Asna, if you're comfortable discussing with me, do you know the 12 cranials name 1 to 12? Yes or no?
yes, yes.
Tell me one by one. You only speak first.
Okay. So olfactory nerve is the first.
Olfactory. Sorry to take you back into the MBBS days.
Okay.
No,
Optic nerve.
let her speak. Olfactory, optic. Then third,
Then oculomotor.
oculomotor. Fourth,
Trochlear.
trochlear. Fifth,
Trigeminal.
Excellent. 6.
Abducent.
Excellent. 7.
Facial.
Excellent. 8.
Vestibulocochlear.
Vestibulocochlear. 9.
Then glossopharyngeal.
Glossopharyngeal. You are very
Vagus
close.
nerve.
Vagus. 11.
Accessory.
Accessory.
Spinal
That's fine.
accessory nerve. Spinal accessory nerve.
Excellent.
Hypoglossal nerve last one.
And yeah, hypoglossal.
Wonderful, Ashna. I'm so impressed with you.
Thank you, sir.
Very nice. Very much impressed. I mean, though it looks easy, but we forget, isn't it? We forget now how many cranial nerves and what. So there are 12 cranial nerves which start from the olfaction. Here the olfactory, then optic, then oculomotor, trochlear, trigeminal, abducent, facial nerve, right? Then hearing, vestibulocochlear nerve, right? Vagus nerve, glossopharyngeal, spinal accessories nerves. So all cranial nerves, right? So this abducent nerve, the answer is abducent nerve, means cranial nerve 6, cranial number 6, if I'm not wrong, isn't it? Yes or no?
Yes, sir.
So main job of cranial nerve 6 is what? What is the main functions of 6th number cranial nerve? Abducent nerve. What's the main functions of the abducent nerve?
It supplies only lateral
rotation of the eye.
True, that's correct. So lateral rotation of the eye. So abducent nerve palsy, child gazing to the right? So when she is moving or is moving the left, he cannot able to do the lateral rotate. Otherwise, both eyes goes together, right? Right and left. Isn't it? Yes or no?
Yes.
So patient is unable to adduct the right eye while the abduction of the left eye is intact. So she can. Fair enough. So this is 6 cranial now. This is little complex picture from the one of the journal while doing my research on your presentation of today. I got this, but I love this picture, so I thought let me share with you. Though you knows everything, everybody knows everything, but this is a good picture. In one picture, you see olfactory now, optic now, oculomotor now, right? Then here they have a different name, right? So it's all correct. Olfactory, optic, oculomotor, then number 4 trochlear, then 5 is trigeminal, abducent, facial, vestibulocochlear, hypoglossal, vagus, accessory, and hypoglossal. Is that clear? So this all various nerves and what the various functions, sensory, motor, right? So I'm not going much in neurology as of now, but this is the things which you need to know, right? Olfactory nerve, sense smell, optic nerve is sensory, optic nerve. Oculomotor is motor somatic and motor parasympathetic, trochlear is motor. Trigeminal is sensory and motor division, so you can do some research later on. I have a lot of things to tell you, but time constraint. Abducent nerve, our answer is abducent nerve. For our scenario, abducent nerve, it's a motor. Motor means muscle, right? Managing the muscle movement, eye movement. Lateral rectus muscle is responsible for abduction. So if it is a paralysis of the 6th cranial nerve or abducent nerve, then you may have difficulty in this lateral movement of the eyes. So that's it. This is what the thing is for things. And if you allow me, I will discuss one more questions and then we have a feedback session. Upper and right. So this is what the question is. Let me erase the thing so you can visualize my MCQs well. Upper motor neuron lesions are characterized by all of the following except. Options are Babinski sign positive, increased stretch reflex or hyperreflexia, increased muscle tone or hypertonia. Stroke is the one of the etiology of upper motor neuron lesion. All of the above seen in upper motor neuron lesion. So try to understand simple one-liner question. Upper motor neuron lesions are characterized by all of the following except. So one is not there. or all or above are also correct. So what do you think? So anyone, any volunteer who discussing the questions with me, I want to understand most important thing here. What is the upper motor neuron region? What is the lower motor neuron region? Because I know even when I was a student, I was little confused between this. So there are few doctors who confuse. So what is the site of the lesion? Where is the problem in the upper motor neuron region? Where is the problem in the lower motor neuron? What is the sign and symptoms of upper motor and what is the sign and symptoms of the lower? What are the causes of upper motor neuron and lower motor neuron? And what is the treatment of upper motor neuron and what is the treatment of lower motor? This is by my language called as a head-to-head comparison. And this is one of the best technique in by my experience. All right, this is best technique when you know clear cut differentiating between these two things, or this Hodgkin's lymphoma, non-Hodgkin's lymphoma, AML, ALL, CML, CLL, osteoarthritis, osteomyelitis. Like that, if you know the head-to-head comparison, it brings more clarity to you, right? What you are exactly doing in your practice or how you differentiate in clinical from one to another. Yes, go ahead. Anyone?
All are signs of upper motor neuron lesions.
Sorry, sir.
Yeah, all of the above are seen in upper motor neuron.
Okay, so any one volunteer tell me where is the problem in upper motor neuron region?
So the
Anatomical.
upper motor
Pyramidal and
neuron means all the cortical neurons and their projection till their sinus till lower motor neuron. Cortical neuron and their projections.
So can you name the organ, name of the organ where the upper motor neuron lesion could be?
It can be in the brain. It can be cerebellum. It can be in midbrain. Even spinal
Got
cord
it.
can
So
lead to upper motor neuron.
wonderful. So three things I'll write down just to make it more clarity: brain and spinal cord. So in brain, two things I will write: cerebrum and cerebellum, isn't it?
Yes.
And spinal cord, right? And what
The
is
spinal
the
cord can even.
right? And where is the problem in lower motor neuron?
That is in anterior horn cells of the spinal
Excellent.
cord.
Anterior horn cell. What else? One is anterior horn cells. Well, so if anterior horn cells damage, you may get lower motor. This is the only thing, or there is something else as well?
No, their projections. Their projections.
Corticospinal tracts, spinal all the spinal tracts.
Spinal tract. What about
Spinal tract.
neuromuscular junction? What about the muscle itself?
Muscle.
Neuromuscular junction
Peripheral
and
nerves.
even peripheral nerves.
Peripheral nerves. Excellent, excellent, excellent. I want you to give the concept, not the mug up. That is why I'm going between basic things. Because once you understand these things, I don't think the problem for you to understand any clinical dignity or scenario. So this is absolutely fine. I have a tremendous picture for you to show to make it more clarity. What is the sign symptoms here in upper motor? We know where is the anatomical problem. Now what how they present? If someone has upper motor neuron lesion, what's the impression in your mind? How do they present?
Upper
Increased
motor
tone.
neuron is
Hyperreflexia, increased tone,
spastic
spastic paralysis,
whereas
Fair
lower
enough.
motor
seizures,
Fair enough. And lower motor is
hypotonia, and decreased reflexes.
wonderful.
Then
Wonderful.
fasciculations are present in lower motor neuron region.
Excellent. Excellent. Are you neurologist, Dr. Asna? Sorry, curiosity question.
No, sir, I'm not.
Great. You're neurologist. I need to learn from you. Teach me sometime neurology. Great, wonderful. So this is all, you all are correct. Wonderful. So let's go to the easier things. I love to find out the easier things. Probably I'm very excellent in making the things presentation easy. So this is up, right? So green is upper motor neuron. So this green start from the cerebrum, cerebellum. This green comes here up to here. So brain, this is cerebrum, cerebellum, midbrain, hindbrain, forebrain, and cerebellum, all part of. So if you have stroke, say for example, stroke, so you gonna see the upper motor neuron lesion, isn't it? Yes or no? Yes or no?
Yes, sir.
Yes.
So something goes wrong in the brain, cerebrum or cerebellum or spinal cord, you get upper motor kind of things. Now let's come to the lower motor. So as sir rightly told, anterior horn, so where is the anterior horn? This is anterior horn, right? Second thing is from anterior horn, right? Right, this green is upper motor. It ends here, and from here lower motor neuron. So here the nerves, peripheral nerves, where the nerves and muscle meets, it is called as a neuromuscular junction, and this is muscle. Isn't it? Yes or no? At least tell me yes or no.
Yes, sir.
So
Yes.
anything wrong here, you get a lower motor neuron. Anything wrong here, you can see the upper motor neuron because they are upper. Now, very important and very simplest definition or classification. I love head-to-head comparison for all condition. That is why I give head-to-head comparison. Upper motor neuron, cerebellum, cerebrum, brainstem, spinal cord. Lower motor, anterior horn cell, nerve root, neuromuscular junction, muscle. Is that clear? So sight, where is the problem? So this is sight. How the muscle weakness presents. So here quadriplegia, primarily because of stroke, hemiplegia, primary because of stroke, diplegia, triplegia. So any plegia or paralysis is upper motor neuron because the problem is in the brain, not in the peripheral. Here, lower motor neuron proximal, when the muscle is involved, it is myopathy, now involved neuropathy. So myopathy and neuropathy are there. Is that clear? Yes or no? Remember that picture.
Yes.
If you remember my picture and think, things will be easy. Remember this, upper motor means all up, lower motor means all low. What do you mean by all up? Reflex is up. So hyperreflexia. Tone is up, hypertonia. Up means high. Up means high. Up is high.
Front reflex going upward.
So Babinski, right? Yes. So hyper spasticity. Here hypo, low, lower motor is equal to low or hypo. Upper motor is up or high or hyper, right? So either hyper spasticity, hypotonia. Here the hyperreflexia, here hyporeflexia, right? Here the sensory loss is cortical sensation, here the peripheral sensation now loss. EMG, electromyogram, normal. Why normal? Because nothing to do with the nerves, peripheral nerves. Isn't it? Yes or no? Because upper motor doesn't involve the nerves. So normal nerve conduction study, or we called in our clinical practice NCV. Isn't it? We many a times order EMG NCV, right? And here the slow nerve condition, right? Large motor units and fasciculation and fibrillation. And treat the underlying cause. What is how you treat? Treat the underlying cause. Treat the underlying cause. That's it. So this is what the upper motor and lower motor neuron paralysis. Is it easy for you guys now? Yes or no? At least tell me yes or no.
Yes, sir.
Right. You
Yes,
bring
sir.
more clarity on upper motor or not? Upper, lower.
Yes. Very.
Wonderful. So this is what the thing is. This is what I told you. Upper means all up, tone up, reflex up, pyramidal tract side. Lower means all low, tone low, reflex low, atrophy, fasciculation. That's all. And this is again the same thing, right? So upper and motor. So upper motor, more muscle contraction, spasticity, more muscle tone, hypertonia, more muscle reflex, hyperreflexia, more diffuse atrophy, and toes point up. Upper motor up, all up. I told you, all up. So Babinski is up. This is Babinski's up. Lower motor, Babinski down, low. So that's all from my side for today. Thank you very much all for listening me coolly and calmly. Probably I spoke for 90 minutes now. So thank you very much. I would like to, would you like to discuss one MCQ or I'll pack up?
Sir, one more.
Excellent.
sir.
Wonderful. Wonderful. Interesting. One more. I have almost more than 5,000 MCQ on our website. Same thing. It's all from website. Which of the following is not true for heparin-induced thrombocytopenia? Which is not true? HIT type 1 is non-immune and type 2 is immune. True or false? HIT means heparin-induced thrombocytopenia type 2 can cause thrombosis. True or false? Unfractionated heparin and LMWH can cause low platelet. True or false? Observation is treatment in HIT type 2. True or false? Or like upper motor, all of the above are true. So take your time, think over it, and then we'll discuss this heparin-induced thrombocytopenia and we'll pack up. Post your answer in the chat box. So far, I did not get any answer. Yes, Dr. Jamal, what's your comment?
Option C.
I think, sir, all are correct because this type 1 is non-immune and unfractionated and lower can cause low platelet.
Fair enough. So
And
we'll see what's the answer.
I'm sure about the three.
No
I'm
problem.
sure.
No problem. This is what the interesting thing, because heparin-induced thrombocytopenia, every doctor has seen in their OPDs and IPDs and ICU and neuro ICU and surgical ICU and all ICU. Heparin is commonly used drug in ICU, and this type of reference I'm getting every day. One reference I'm getting from ICU, sir, platelets are 10,000, platelets are 20,000, platelets are 30,000. This has a DIC, this has a septicemia, this has a drug induced, this has a piperacillin tazobactam induced. There are hundreds of reasons in ICU. Yes, Dr. Sandhya.
Yes, sir.
Okay, let's see. Dr. Aminu Umar. Comment, Dr. Aminu. Yes, sir. Comment. Same question will come in exam. What you gonna suppose?
Answer should be E, because HIT type 1 is also non-immune.
So
And
HIT
type
means
2
heparin-induced thrombocytopenia type 1 is non-immune and type 2 is immune. It's a correct answer.
It's a correct answer.
It's a
So,
correct answer. So if you are giving the answer, it's a correct answer. Heparin-induced thrombocytopenia type 1 is immune, non-immune, and type 2 is
yes.
immune.
So
What
I
they are
think the
asking,
answer should be E.
E, all of the
Because
above. So let me
all
tell
of
you,
them.
those who has given the answer E is not correct. Still, there is a one incorrect sentence in A2, A, B, C, and D. There is a one incorrect answer.
I think D is not correct. I think.
So, sir, it looks difficult question, sir,
I
to you.
think
C.
the
C
answer should be
answer.
C.
Answer is C.
C.
Confused.
No, C is a
Because
correct answer. C is a correct answer.
C is correct. C is correct.
Any
C.
form of let me tell you, being a hematologist, any form of heparin, whether it is unfractionated heparin or low molecular heparin, both can cause thrombocytopenia. Unfractionated heparin, percentage wise, if I can tell you, 10 to 20% of the patient who are on unfractionated heparin, they develop it, and less than 2% or 5% develop with a low molecular. So incidence and prevalence is less in LMWH group than unfractionated heparin, but it can occur in both. So C sentence is correct for your knowledge. Yes, Dr. Naz, any comment? Dr. Naz has given the comment D, observation. If you are in position to speak with me, Dr. Naz, I would be glad and happy.
Yes, hi.
Hi, how are you, ma'am?
Yeah, I'm good. So it's because it's immune mediated, so we need to treat it.
Excellent. Wonderful, wonderful. So
Yeah.
what is the major complication with heparin-induced thrombocytopenia type 2? Bleeding or thrombosis? Or both?
Thrombosis.
What's your
Thrombosis.
Thrombosis. Wonderful. Thrombosis. If you
Thrombosis.
don't mind, I can ask you some more questions to bring more clarity to you and me. So which
Mhm.
thrombosis? Arterial thrombosis, venous thrombosis, or both?
It can cause DVT. Yeah, it can also cause.
Venous.
Venous.
Yeah, venous mainly. I
Fair
think.
enough.
No.
Okay. Fair enough. Fair enough. So now says you have a patient of heparin-induced type 2 thrombocytopenia. You are a physician, internal medicine, the way we spoke, I remember. So probably heparin is a day-to-day job here there in Dubai as well, right? In many ICU and emergencies. So what is the main complication of HEAT 2? So thrombosis, right? So what investigation you wanna do, right? And how you suspect that this patient has the heparin-induced type 2? How you differentiate from type 1 head-to-head comparison? When patient comes to you after 10 days of, say, low molecular weight heparin, how you gonna suspect it is type 1 or type 2?
I think type 1, this is what I think, that
Yeah, no
I'm not
problem.
sure if
You go
I'm
ahead. Fair
correct,
enough.
that
Fair
I
enough.
think type 1 would be more earlier, like it occurs because it's non-mediated, it's like a reaction, so it will be earlier.
Wonderful, ma'am. You are absolutely going well. Yes.
Yeah, and then type 2 would be after maybe 10 days.
Fair enough. Fair enough.
Yeah.
Second, once you had a type 2 thrombosis, how you gonna manage? What anticoagulant you use? Because there is a thrombosis, there is a heparin-induced thrombosis type 2. So is there any protocol or how you supposed to treat these patients, or what's your experience in the past, if you have treated, or anything you heard about? Because this is one of the most common challenging things I'm facing in my ICU in India, right? Every day I'm getting ICU reference. So I always think of heparin is going or not to the patient. And if it is heparin induced type 2, what am I supposed to give to the patient? Oral, IV, sub-Q, which drug, what dose, name of the drug, recent molecule, blah, blah. Any idea?
Enoxaparin.
I think we shouldn't use non-heparin anticoagulants like fondoxaparinax or directly acting anticoagulant like rivaroxaban, apixaban.
Fondoxaparin, any
Rivaroxaban.
LNWH. No, sorry to interrupt you. Just first treatment, sir, for any heparin-induced thrombocytopenia is gold standard. Stop the heparin in any form. Simple and sober. Stop heparin in any form, whether it is unfractionated, fractionated, low molecular, high molecular, whatever molecular. There should not be any heparin, because heparin primary molecule is the culprit for developing the heparin-induced thrombocytopenia. Isn't it? Yes or no?
Yeah.
Right. So first and foremost is to stop the heparin in any form. That is more important. Second step, you stop the heparin. That what you give to the patient. You need to resolve the thrombosis, isn't it? Because thrombosis is there, right? And this is probably very few senior doctors like Dr. Naz has seen such type 2. It's not that common. Even in my hematology practice, I treated 2 to 3 only, which is absolutely labeled as a HEAT 2. We shortly called as a HEAT 2, means type 2. So what you give to this patient? Any name of the drug? Commonly drug, which is like
we can use apixaban.
Apixaban is, yes.
Fondaparin.
Argatroban or apixaban.
Argatroban, I guess, something like direct thrombin. Thrombin inhibitor.
Exactly. The ma'am is showing, Dr. Naz ma'am going great. Yeah. So direct thrombin inhibitor, because there is a thrombus, so you need to resolve. So heparin-induced thrombocytopenia is a literature from another international book, not from Master the Board definition. Antibody media. Oh, sorry. Let me first give you the head-to-head comparison that brings more clarity to you. So I love this comparison. So type 1 and type 2, right, for the understanding. So type 1 is clear-cut non-immune mediated. This is immune mediated, clear-cut. Epidemiology, incidence prevalence, 10 to 30% of the unfractionated heparin treated patients develop HEAT 1, right? And here up to 5%. So this is the things. Any form of heparin can cause this, though it is a less, right? But it is there. Right? Pattern is between 1 to 4 days of unfractionated. So you've started intravenous heparin to one patient, right, for DVT, say for example, within 4 days or 5 days he developed with a low platelet count. Before starting heparin, platelet count are 200,000. Let me remind you the normal count 150 to 450,000 is the normal platelet count. This lady has a normal 2,000, but after you start on the day one, it is 200,000, then 175,000, then 150,000, and on day fifth, he has only just 70,000. Means something wrong after starting the heparin, isn't it? Yes or no? Are you getting me? Yes or no?
Yeah, yeah.
Yeah, so this is
Yes, sir.
within 1 to 4 days, and here it takes some time because the antibody which required, so it usually late after 44 to 16 days of initiation of low molecular weight heparin or blah blah, right? So you need to see the time frame, right? Time frame. What is the time frame? Again, severity of the thrombocytopenia is important. This is non-immune, so this is non-serious. Non-immune, non-serious. Immune, serious. So platelet count usually, even I have seen in many patients not going less than 100,000. Here they can go up to 60,000, or I have seen the patient recently who has a 10 to 20,000 fluctuating, right? With thrombus, and thrombus, where the thrombus is in the left atrium. So we did a 2D echo for that patient. As a routine, we did a screening of the lower limb veins, deep vein thrombosis, venous Doppler, we did it, arterial Doppler, we did it a 2D echo, all right, as a baseline, and we found the clot in the left atrium as well in my patient. And platelet count is fluctuating between 10 to 20,000, right? It is, you can find the antibody mediated, so there mediated, no, it is non-immune, so there is no antibody. Here the antibody, right? So platelet factor 4 antibody, you can heparin platelet factor 4 antibody, which you can measure in the serum. It is available, don't worry, it's not a very fancy test, though it is a less performed test, but it is not fancy test, you can do it. Thrombosis common? No, thrombosis is not common. Non-immune, right? Type 1, non-serious, no clot. Here clot, is that clear? Thrombosis means clot. Are you getting me? Yes or no? Right?
Yes, yes.
Management,
Yes, sir.
observe means you just need to stop. That's it. You stop the any form of heparin. It is non-immune, non-serious, non-problematic, but you need to stop. Otherwise, it keep worsening. Right? Here, observation is not a treatment. That is take-home message. You cannot observe heparin-induced type 2. You stop the heparin, that is for sure. Discontinue heparin and start treatment with DTI, direct thrombin inhibitor, as Dr. Nas told already. So DTI is absolutely, so what was the option, right? The observation is, so D here, if you can see and go back to my MCQs questions, now you get the idea. Type 2 is non-immune and type 2 is immune. Correct or false? Correct. Type 2 can cause thrombosis, correct or wrong? Wrong. Correct. Unfractionated heparin and low molecular can cause low platelet, correct or wrong? It's correct. Both can cause. This cause 20%, this cause 5%. Observation is treatment for type 2? No, wrong. Observation is not a treatment. You cannot observe. You stop the heparin and start direct thrombin inhibitor. That is why this is not correct. What is not correct or not true amongst this? This is true, this is true, this is true, and this is not all of the above, because this is not wrong. Is that clear? Yes or no? At least tell me yes or no.
Yeah. Yes, sir.
Yes, sir.
Wonderful.
Yes, sir.
Wonderful.
Yes, sir.
Wonderful. 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 So that let's little go ahead and pack up the things shortly. Probably you are tired as well. So
No, sir, we are
heparin,
not tired.
so thank you very much for your energy level. I am also not tired. I love my flow of. Yeah, so heparin-induced thrombocytopenia, antibody-mediated response to the heparin leading to thrombocytopenia, increased risk of thrombosis. Can you see? They have not mentioned increase the risk of bleeding. Isn't it? Yes or no, Dr. Nas? There is no increase the risk of bleeding, increase the risk of thrombosis. Isn't it, doctor?
Yeah, yes.
Excellent. The incidence is not that low, not that high, 0.1 to 7% patient receiving heparin product. Risk factor is female sex, surgery, trauma, unfractionated heparin, more than fractionated, but both can cause. Duration, here we are discussing mainly type 2.
Type 2.
Right. And a diagnosis, how you gonna diagnose this heparin? So CBC, right? You can see the progressive thrombocytopenia. Obviously, this is heparin-induced thrombocytopenia, peripheral smear. Coagulation study, PT-INR you need to do, and right, to just rule out from the other condition like the septicemia, DIC, blah, blah, right? And the confirmatory test, that what we are interested, I told you already, platelet factor 4 heparin. So heparin platelet function 4. right? This is the immunoassay, functional platelet activation assay. So you ask for the PF4, platelet factor 4 heparin immune, because heparin and platelet, heparin induced platelet reaction. So heparin platelet factor 4, like that, blah, blah, right? And treatment stop all heparin exposure. Can you see the word beauty? All heparin. They have not mentioned on fractionated. All heparin. Every word is golden sentence. So all heparin in any form. Initiate non-heparin anticoagulant, as Dr. Jamal told. Initiate non-heparin anticoagulant, not the heparin, because heparin is culprit. So you don't need to use the heparin. Isn't it? Yes or no?
Yes.
Wonderful. And last but not the least, screen for the thrombosis. So any patient with the heparin-induced thrombocytopenia, whether they have a symptoms or not, you must screen them for, I'm doing mute all, right? A lot of background noise. So screen for the thrombosis, right? So thrombosis, you must screen for every patient for the thrombosis. So, though they have not symptoms, right? You must have to screen them. So what you screen them? What are the commonest screening site basically? So deep vein thrombosis. So you do the venous Doppler of both limb. So venous Doppler, arterial Doppler. You can do the abdomen tummy for mesenteric ischemia or so. You can do the 2D echo just for the clot in the things, and probably you can look at the carotids thrombosis as well. These are the common site for heparin-induced thrombocytopenia, let me tell you, right? So that is the things, and how they present, as you know, rightly correct, right? The sign and symptoms, right? New onset of neurological deficit or stroke, chest pain, because so wherever the thrombosis, you have the symptom. That's it. Depends on thrombosis. If it is abdominal, abdominal. If it is in the chest, it is chest. If it is in the lung, embolism. If it is in the limb, blah blah. So this is what the thing is, right? And this is the 4T score, probably pre-test probability. We call it as a 4T score. What is 4T score? One is the thrombocytopenia is there. So you need to look for, whenever you diagnose heparin-induced thrombocytopenia, you need 4 things in your mind. Thrombocytopenia is there or not? Yes or no? Yes. Ask the second question. What is the time frame which defines you from the 1 to 2? Dr. Naz, isn't it? Yes or no? 1 to 4 is type 1, and more than 4 to 10 probably it's a 2. Isn't it? Yes or no? Look at the thrombosis and other complications as well. And never ever miss the other causes of thrombocytopenia, which is not heparin induced, right? Otherwise, you will misdiagnose the patient, right? And in ICU, many times what happen? Heparin is going, lots of antibiotic is, lot of antibiotic drug is also going, lot of other antibiotic drug is also going to the patient, right? So you are sometimes confused, right? What it caused. So you need to need to look at the thrombosis. You need to look at the heparin use. You need to look at the time frame.
जब बाहर घूम के आ थोड़ा बहुत मार्केट में जा, खैला मस्जिद पे जा, अंदर बैठा हुआ है.
1 second, why this guy is not understanding? Yes, sorry, I muted all. So that's it. So this is what 4T you need to keep in mind. So that's all from my side. Thank you very much all for your kind attentions. Hopefully,
Thank you very much.
I
Thank you,
did
sir.
my level best. So I would like to
Thank
have
you,
quick
sir.
feedback on the
Thank you,
session.
sir. It was
How
very
did you
nice.
enjoy it, and
Thank you, sir.
how you enjoy this session?
Thank
I
you
would be
very
glad
much,
and
sir.
happy to have your quick feedback. Yes, please. Anyone. I mean, it's not
It was very informative, sir. Thank you so much.
wonderful. So what is the new learning for you today? I mean, probably these all are the common topic you must have heard, but what's the difference in your reading and my preparation and my presentation, or what you feel that this is, sir, absolutely new I learned today? Is there anything?
Yes, sir. The stepwise approach, the question, especially.
Okay.
And
And
we all used to
addressing
focus.
multiple questions in a single question.
Wonderful. Wonderful. Yeah, we need to know, no, because they ask anything. So our job
Yes.
is not to just mug up the things. Our job is to understand the topic. So
Yeah.
that would be long-lasting memory.
And I would like to say that your triad is very awesome. Investigation, diagnosis, and the treatment.
Wonderful.
Treatment
I love
like
it.
them.
diagnosis.
I love it because I do for last 20 years in my practice as well. So tomorrow I
Yeah.
have a big OPD. I'll ask myself 3 questions when I'm seeing patient. What is the diagnosis? How you supposed to investigate this patient and how I supposed to treat? You understand? So that makes my job even easy in day-to-day practice.
Okay, sir.
Yes, of course, sir. It's also beneficial to you also, sir.
Yes, absolutely, sir. Absolutely. Anyone else? Any
So you
comment?
eliminating the
Sir,
fear
your
of
way of
each
teaching
and every
really,
topic.
Sorry,
That is
sir.
so
sir,
important.
Yes, Safura, what you are saying?
So
sir,
you are eliminating like fear from like subject wise. So that is very important for me.
Wonderful. Wonderful. So this is
Yeah.
how we need to
Thank you.
do and how this is how we need to prepare for our exam or anything, right?
Of course. Thank
Systematic
you so
approach
much.
rather than random.
Thank
We are
you
just
very
reading
much.
it. We don't know what we are reading. Yes, please. Anyone?
yes,
It
sir.
was
What?
very enlightening. Thank you very much.
You are welcome, sir. My pleasure to be you in the class. Don't miss
we
out. We have
learned.
same every Sunday, the same class, 12 to 2:30. But sorry for today because I have a late flight, 12 hours from Dubai to Ahmedabad. So I did not took rest. I came 2-3 o'clock and I started here. I don't want to miss this class.
Thank you for your
Thank
efforts,
you,
sir.
Dr. Munjal. Thank you very
Thank you
much.
so much for your efforts, sir.
No
But
problem.
your way of teaching really so wonderful.
Thank you very much.
I don't have any
Sir.
alternative of your teaching. Sir, I think, I'm sure that there is no alternative of your teaching.
No, we have many coach on the board and all are brilliant, sir. All are
Nobody's
expert in
like you.
the, all are
Nobody's like
expert.
So wonderful and so easy.
No, everybody
His
is
approach is
wonderful. You attend our other coaches as well, Dr. Maddy, Dr. Aarti. They are brilliant speaker and they
Yeah,
are
of course,
expert.
but sir, there's no option for you.
Thank you very much.
Yes, sir. Yes, really
No option
true.
of you.
No problem. Thank you.
Sir,
Thank you,
your
sir.
way of
Thank you.
teaching is so wonderful.
Thank you very much, sir. I'm learning.
So, sir, no better than from
we are
you.
learning
And
from
even, sir, you are so energetic. Really.
Thank you very much. I'm learning medicine.
Yeah.
we
No,
have to
sir,
learn that.
you are a great.
No. Thank you very much once again. If anybody
How
wants to have
often
any
are we
last
going to be having these sessions?
last comment.
Sir, a question.
Sir, last comment, you may live long.
There is a question, sir.
These questions are on our website, sir. These all questions are on our website.
Okay.
No problem. You have my number, I mean, or Pallavi's number, or we have big team. So this is my number on the bottom. So you can have it. Right? You message me if you need any help or anybody need any help. Okay, thank you very much all once again. I appreciate your precious time.
Thank you,
Thank you
sir.
very much.
Thank
Stay
you, sir.
tuned.
Thank you, sir. You are excellent, sir.
Thank you very much. And don't miss out the next Sunday class. We'll see you at
Okay,
12
okay,
o'clock.
sir.
Now I'm in India.
Okay.
Thank
Okay,
you
sir.
very much.
Thank you,
Take
sir.
care. And this
Thank
video
you.
is also available on the YouTube channel. So one
Yes.
request, those who did not subscribe, you can have. I have hundreds of same video, all different questions, not a repeated one. You can see at least one video a day. I think if you are busy driving, going from one place another, just having earphones, you get a lot of clarity. You save the time and you learn a lot of things. Same video, more than hundreds of videos are there on our YouTube channel, free access.
Okay, sir.
Thank you very much.
Thank you, sir.
Take care.
Thank you, sir.
Enjoy.
Thank you, sir.
Bye. Take care.
God
Thank you
bless
very
you.
much.
Thank you very much.